Good day, everyone. This is the exercise 2 on systematic veterinary pathology laboratory, discussing the pathology or the diseases of the gastrointestinal system. With me are my group mates, Miss Baez, Miss Irandio, Miss Ponferrada, Mr. Resma, and Miss Williams. In this exercise, we will recognize and describe the gross and microscopic findings in the GIT diseases and identify the causes and discuss the pathogenesis of the GIT diseases. Our report will primarily focus on fascioliasis in cattle, infectious canine hepatitis, and canine parvovirus. All right, the fascioliasis in cattle. So, fascioliasis is a chronic parasitic disease that primarily targets the liver of the ruminants, such as cattle. It is caused by the liver flukes and is a major concern for the livestock industry because it leads to significant economic losses, to reduced productivity, weight loss, and high mortality rates. The disease progresses through two distinct phases: an acute stage involving early fluke migration and a chronic stage once the adult flukes have established themselves. Now, in cattle, the presence of these flukes causes severe hepatic dysfunction, characterized by also fibrosis or the scarring of the liver, and, of course, bile duct hyperplasia. This condition also leads to anemia, which impacts both the digestive and the circulatory systems. Therefore, it is important to note that fascioliasis is often worsened by secondary infections and is most prevalent in temperature, humid regions that support the snail population required for its life cycle. Furthermore, this is a zoonotic disease, meaning it can infect humans through the consumption of contaminated water or vegetation. For the etiologic agent, the primary culprit behind this disease is the Fasciola hepatica, commonly known as the common liver flu. Taxonomically, it belongs to the family Fasciolidae and the genus Fasciola. It is digenetic trematode, a type of a flatworm that requires two different hosts to complete its complex life cycle. For its transmission, it occurs when a cattle graze in a wet or marshy areas and ingest metacercaria, or the encysted larvae that is found on the vegetation. The life cycle depends on the freshwater snails, specifically from the genus Limnaea, which serve as the intermediate host. Inside the snail, Miracarcidia hatch from eggs in feces, develop into cercaria, which then leave the snail to insist on plants. Environmental factors like flooding, poor pasture management, and moist climates are critical for sustaining this cycle. As for its clinical signs and diagnosis naman, the clinical presentation of fascioliasis vary by stage. So, acute phase, that is 2 to 6 weeks post-infections, where the animals may show fever, lethargy, abdominal pain, and in severe cases, sudden death due to liver rupture. For chronic phase naman, that is around weeks to months, this is characterized by a progressive weight loss, anemia, visible as pale mucous membranes, and submandibular edema, commonly known as the bottle jaw. Other signs include diarrhea, jaundice, a rough coat, and reduced milk production. In advanced cases, cattle may suffer from ascites or fluid in the abdomen or heart failure. For diagnosis, we rely on fecal egg counts, serology, or findings during necropsy.
So hello, in this segment we are going to tackle about the pathogenesis of our fasciolasis in cattle. So what are the stages or what are the migration patterns and how does this affect the system? So here we have here the ingestion of metacarcariae, and we also have exgestation in the intestine. We also have intestinal penetration, the migration to the liver, the parenchymal migration, the entry into the bile ducts, the chronic biliary irritation, and functional consequences. So those are the subtopics under this subtopic that we are going to tackle. So ingestion of metacarcariae. So here the cattle becomes infected by ingesting the metacarcariae of the Fasciola species, either the Fasciola hepatica or the Fasciola gigantica. It is attached in aquatic vegetation or present in contaminated water. So once the snail or the intermediate host carries it, and when it attaches or magpabilin sa ato ang mga contaminated water or vegetation, then the cattle or the animal would then ingest it, and it will enter into the system. Next is the excitation in the intestine. So after ingestion, the metacercariae exist in the duodenum, releasing immature flukes. So this is where they try to try to get out of the capsule-like structure. Then they would embed themselves into the intestinal wall and thus releasing the immature flukes. Then moving on to the intestinal penetration, where the immature flukes penetrate the intestinal wall and then enters the peritoneal cavity, causing mild local tissue damage. After penetration to the tissues, then the migration to the liver happens. The parasite migrates to the liver capsule and penetrate the Glissen's capsule, and thus entering the hepatic parenchyma. And there, the parenchymal migration happens, wherein this is also characterized as the acute phase, where the immature flukes tunnel through the liver parenchyma, feeding on hepatocytes and blood. After the acute phase, wherein the parenchymal tissue would then be filled with holes or perforations wherein the passes through. Next is the chronic phase, or entering the chronic phase, which is the entry into the bile ducts. After several weeks or chronic time, the flukes enter into the bile ducts where they mature into the adults. They they then would cause chronic biliary irritation, wherein the adult flukes cause persistent irritation in the bile duct epithelium, leading to chronic inflammation, bile duct hyperplasia, fibrosis, and duct thickening. So this is where they try to irritate the biliary ducts, wherein they would lodge themselves or obstruct the ducts themselves, would cause irritation, inflammation, and thickening or fibrosis. So what then are the functional consequences? So of course there is progressive liver damage, which results in reduced liver function, hypoproteinemia, anemia, reduced weight gain, and productivity. So how does this happen? First is reduced liver function. Of course, because the parenchyma is damaged, the function or the functional tissues are lessened. And also during chronic phase, the parenchymal tissues are converted into fibrosis, or the functional tissues would turn into fibrous, and that would affect the functional state of the organ. Hyperproteinemia, wherein the parasites or the flukes themselves that feeds on the plasma proteins would feed on the plasma proteins, and that would cause the hypoproteinemia. Anemia, of course, that would also be an effect. Reduced weight gain and productivity, that's because the liver is known to be the production of enzymes and metabolic activity, and without the functionality or lessened functionality of that, there is reduced weight gain and productivity overall. So this is an overview of how the parasite or the Fasciola species travels through from the intermediate host to the definitive host and cycle. So here are the gross lesions observed in the fasciolasis in cattle. Of course, there is liver enlargement, hepatomegaly. That's because of the inflammation or the consequences of the any entry of those flukes, migratory tracts, or hemorrhagically in the liver parenchyma or hepatic parenchyma, hemorrhages in necrotic areas, fibrosis in the bile ducts, wherein there would be thickened bile duct walls and fibrosis presenting besides the functional parenchyma. There's also a calcification wherein it is also described as a pipe stem liver and also ascites occasionally presented. As you can clearly see, there are holes that are found here, and those are the migratory tracts wherein the flukes traveled through. So here is an example of the fasciola parasite indulge in the biliary tracts, and there are also calcifications and thickening of the biliary ducts, and that would mean that this is a chronic phase, or this has entered into the chronic phase. Microscopic lesions observed in fasciolasis. So there are hepatic necrosis, of course, due to the death of hepatic parenchyma tissues. Hemorrhage, of course, because of the perforations and the damage in the blood vessels that is in the parenchyma. Inflammatory cell infiltration, specifically eosinophilic infiltration due to the associated parasitic infe- infestation. Fibrosis replacing the functional parenchyma. Bile duct hyperplasia wherein the bile duct would increase the numbers and resulting to gross lesion of thickened biliary ducts. Cholangitis is also present as well as calcification. Here is an example of histological site wherein the mature flukes is observed, or a fluke is observed, as well as eosinophilic infiltration and inflammatory inclusion bodies. And we can also observe that there is a damage in the parenchymal tissues, and also erosion, ulceration in the path wherein the fluke traveled through. So here is another picture wherein flukes are very visible. These are the examples of the flukes no, in their different maturity stage, and the holes that or perforations that are induced are shown here.
So let us move on to the next disease that was assigned to us, which is the infectious canine hepatitis. Specifically, I will be discussing the disease description, etiologic agent, transmission, clinical signs, and pathogenesis. So let's start. Infectious canine hepatitis is a highly contagious disease of dogs caused by canine adenovirus type 1 or CAV1. So the severity of the disease can vary wildly. In some dogs, or it can range from mild illness such as slight fever and lethargy and loss of appetite, while it can lead to severe and fatal disease characterized by acute liver damage, bleeding disorders, and systemic illness. So the virus mainly affects the liver and the blood vessels, causing hepatocellular necrosis and widespread endothelial damage. Because of this, many of the clinical signs will involve bleeding or hemorrhage, edema, and organ dysfunction. So in some dogs now, even after recovery, immune-mediated complications such as the corneal clouding, or what we call as the blue eye, or kidney disease may develop. So although infectious canine hepatitis has become uncommon in areas with routine vaccination, it still occurs randomly or sporadically, and it remains important because it is maintained in wild carnivores such as the foxes and the coyotes, which act as reservoirs. So infectious canine hepatitis is caused by, again, canine adenovirus type 1, or what we call as the CAV1, which belongs to the family Adenoviridae, the genus Mastadenovirus, and it is actually non-enveloped double-stranded DNA. virus. So CAV1 is closely related antigenically to the canine adenovirus type 2 or the CAV2, which causes canine infectious tracheobronchitis. So because of this relationship between the two of them, vaccination with modified live CAV2 vaccines will provide effective protection against the CAV1 infection. So the modified live CAV2 vaccine can be given to puppies as a protective measure against infectious canine hepatitis. So for the transmission, no, transmission of infectious canine hepatitis occurs primarily through the oronasal exposure to urine, saliva, or feces from infected dogs. So the virus can also be transmitted indirectly through fomites, such as contaminated bowls, cages, or equipment, and possibly ectoparasites. So an important feature of this disease is that recovered dogs can shed the virus in their urine for 6 months or longer, which allows the virus to persist in the environment. So although no, the dogs that previously had ICH uh, will recover, there should be a period where they should be observed, for 6 months or longer or isolated because again, recovered dogs can still shed the virus in their urine for 6 months or longer. So CAV1 is very resistant, again, and can survive outside the host for weeks to months, making environmental contamination a major risk factor. So again, the virus can survive for weeks to months outside the host, and it is specifically resistant to ether, acid, and formalin, but inactivated by steam cleaning or 1 to 3% sodium hypochlorite. So for the clinical signs, the incubation period of infectious canine hepatitis is 4 to 9 days, and the mortality rate ranges from 10 to 30%, with the highest mortality seen in young puppies as they are much more vulnerable during that stage as they are immunocompromised. So the early clinical signs include high fever, often above 40 degrees Celsius, which lasts 1 to 6 days. Another sign would be lethargy and depression, and anorexia and thirst. So, as the disease progresses, additional signs may appear, including conjunctivitis and ocular or oculonasal discharge, corneal clouding or blue eye, which is a distinctive lesion present or observed in infectious canine hepatitis, abdominal pain and vomiting, sometimes with blood, hematemesis, bleeding tendencies or coagulopathy, such as petechiae, hematomas, and hemorrhage, subcutaneous edema, especially of the head, neck, and trunk. And despite severe liver involvement, jaundice is usually absent in ICH. However, in rare cases, central nervous system signs such as seizures, ataxia, or blindness may occur, usually secondary to vascular damage or hepatic encephalopathy. So let's move on to the pathogenesis. So the pathogenesis of infectious canine hepatitis begins after the dog is exposed to canine adenovirus type 1 through the oral or nasal route. So from or during the first 1 to 2 days, the virus will enter the body and initially replicates in the tonsillar crypts and regional lymph nodes. So at this stage, no, clinical signs are minimal or absent, although mild fever may begin. So by days 2 to 4, no viremia will occur as the virus will enter the bloodstream. So this allows the virus to spread throughout the body, particularly targeting vascular endothelial cells. So damage to these cells will result in increased vascular permeability, which leads to edema and hemorrhages. So between days 4 and 6 after the viremia phase, the virus will reach the liver where it infects hepatocytes and causes centrilobular hepatic necrosis. So the damaged liver can no longer produce adequate clotting factors, which results to bleeding tendencies or coagulopathy and bleeding disorders. So during this stage of hepatic damage, no, dogs often show vomiting, abdominal pain, and hemorrhage. So after then, day 6 to day 9, no, antibodies will form. So as antibodies form, immune complexes may deposit in the kidneys and the eye. So in the kidneys, it will cause glomerulonephritis, while in the eyes, it will lead to uveitis and corneal edema, which produces the characteristic blue eye, which is usually seen 7 to 10 days after the infection. And after that, from day 10 to day 14, the immune system will begin to control the infection. The liver enzymes will peak around day 14 and then they will gradually decline. So most dogs recover, but some may develop chronic kidney disease or persistent corneal opacity. So even after recovery, again, dogs may continue to shed the virus in the urine for several months, specifically 6 months or longer, which contributes to disease transmission to other dogs na dayan.
For infectious canine hepatitis gross lesions, the most important organ to observe is your liver. So in this case, your liver is enlarged, showing mottled discoloration like pale or red, friability, or also what we call the nutmeg liver. So in this image, it is described as turgid and friable, causing it to rupture easily during post-mortem examination. There is also presence of rounded liver edges instead of sharp margins. So the reason for this is the virus replicates directly inside your hepatocytes and Kupffer cells, causing massive cellular necrosis. So this loss of cells makes the organ friable and weakens its structure. So in this image, we can see the mottled yellow, tan, dark red appearance of your liver. So it is because of the alternating areas of necrosis caused by your cell death and hemorrhage caused by vascular damage. In this image, we are seeing the gallbladder that is thickened. So gallbladder edema is thought to be the pathognomonic lesion of your canine infectious hepatitis. So it is because the plasma and protein-rich fluid leak out of the vessels into the submucosal tissues. Because your gallbladder wall is loose connective tissue, it swells up like a sponge with fluid, creating the characteristic edematous thickening. In this next image, we are seeing the intestines and surrounding tissues showing marked diffuse hemorrhage, giving it a dark red to purple discoloration. So it is because the virus causes widespread systemic infection of the capillary endothelial cells. This weakens the walls of every small blood vessel in your body, causing them to rupture and leak blood spontaneously. We are also seeing your intestinal loops that are thickened, pale to grayish white, and swollen. So this is due to the plasma leakage from damaged blood vessels. Next, we have the blue eye feature that is characteristic of your canine infectious hepatitis. We can see that the cornea appears cloudy and opaque, obscuring the normal clarity of the eye. So it happens during your recovery, not during the acute illness. It is because the dog mounts an immune response where the antibody bind to viral antigens in your bloodstream. So these antibody virus complexes become trapped in the uvea or iris and ciliary body and the corneal endothelium. The resulting inflammation causes the damages of the corneal endothelium's ability to pump fluid out of the cornea. Thus, fluid accumulates in the corneal stroma, disrupting the collagen lattice that normally keeps the cornea transparent, resulting in the characteristic blue haze. Moving on to the microscopic lesions of your infectious canine hepatitis. So in this image, there is a reticular pattern of central lobar and midzonal hepatocellular necrosis and hemorrhage. So your liver contains numerous foci of central lobar to midzonal necrosis, with occasional extension of necrosis from one central lobar area to another. So the sinusoids in the foci of necrosis are dilated and filled with blood, thus the hemorrhage. Next, we have this image which shows affected areas. Within that, there are hepatocytes that are individualized and necrotic and often contain a 5 to 7 micrometer rhomboidal eosinophilic intranuclear adenoviral inclusions. So a moderate numbers of your Kupffer cells and macrophages and lesser number of intact hepatocytes contain magenta to basophilic intranuclear inclusion bodies with occasional cardiomegaly. In this image also, we are seeing necrosis that is prominent at the lower portion of this picture with disruption of your hepatic cord architecture and the cytoplasmic eosinophilia, karyorrhexis, and pooling of blood. We can also observe here the diffuse hepatocytic vacuolar degeneration that is characterized by hepatocyte swelling with cytoplasmic vacuolization and numerous inclusions or inclusion bodies that is pointed by your arrows in the image.
So for this part, I will be comparing infectious canine hepatitis, leptospirosis, and toxic or drug-induced hepatitis. So I will also be discussing their differences and how we distinguish them from one another. So all three conditions involve hepatic injury and may present with depression, anorexia, vomiting, abdominal pain, possibly jaundice, and elevated liver enzymes. Grossly, the liver in all three cases may appear enlarged, friable, and discolored. So because of this overlap, they can initially resemble each other clinically and even during necropsy. However, they do differ in several important ways as infectious canine hepatitis is viral. It targets rapidly dividing cells, particularly the endothelial cells and hepatocytes. The vascular damage will lead to hemorrhage and leukopenia, and one key lesion that helps distinguish infectious canine hepatitis is crypt necrosis in the intestines, along with the intranuclear viral inclusion bodies in hepatocytes and endothelial cells. So if we see hemorrhages, leukopenia, and characteristic inclusion bodies in histopathology, infectious canine hepatitis is strongly suspected. Now, leptospirosis is bacterial and more multisystemic. So it although it causes hepatic injury, it prominently rather affects the kidneys, especially the renal tubular epithelium. So clinically, azotemia and renal failure are common for leptospirosis. Histologically, we do not see viral inclusion bodies. Instead, we may detect leptospiral organisms using special stains or the PCR. So, significant renal involvement together with hepatic lesions will help distinguish leptospirosis from infectious canine hepatitis. Now, for the last one, we have the toxic or drug induced hepatitis, which is caused by chemical injury. So, it primarily affects hepatocytes directly and is often dose dependent. So, there is no infectious agent, no leukopenia due to viral replication, and no crypt necrosis. The lesions are usually confined to the liver unless the toxin has systemic effects. So, a history of toxin exposure or drug administration is a major clue in distinguishing this condition. So that would be all. Thank you.
So now let's talk about your canine parvovirus. So your canine parvovirus is a highly contagious viral disease of dogs, most most severe between puppies aging 6 to 20 weeks old. It primarily attacks your gastrointestinal tract, causing hemorrhagic diarrhea, vomiting, anorexia, and dehydration. Also, in rare cases, can damage your heart muscle or could lead to myocarditis. So its etiologic agent is your CPV2, Parvovirus 2, family belongs to Parvoviridae, genus Parvovirus, and the type of this virus is it is non-enveloped, single-stranded DNA virus, and small icosahedral virus. So now let's talk about the transmission of your canine parvovirus. Sericane parvovirus is primarily spread through the fecal-oral route, so making direct contact with infected dogs is the most common source of infection. However, the virus is extremely resilient in the environment and can also be transmitted via contaminated fomites like your food bowls, cages, floors, clothing, and even human hands. So cleanliness is very essential if you have a dog previously infected with canine parvovirus. So a critical point is that infected dogs shed large amounts of virus in their feces before clinical signs show. So this facilitates rapid and unnoticed spread within kennels, shelters, or households. The virus's environmental stability means that it can persist for months, making control and sanitation essential. So clinical signs uh, include depression and lethargy, reflecting systemic viral inflammation, infection, and dehydration. Anorexia or loss of appetite is also common, followed by vomiting due to irritation and damage to your gastrointestinal lining. Hallmark sign is your profuse, foul-smelling hemorrhagic diarrhea, which results from venous atrophy, cryptocnecrosis, and mucosal barrier breakdown, which leads to fluid loss, electrolyte balance, and secondary bacterial invasion. So, greatly increasing the risk, this increases the risk of septicemia. So, together, these signs explain the rapid deterioration and high mortality rate in the untreated cases of your canine parvovirus.
Good day. I will be discussing the detailed pathogenesis of canine parvovirus infection. So, canine parvovirus is a highly contagious, non-developed DNA virus that primarily affects rapidly dividing cells. Infection begins when a susceptible dog ingests the virus through the fecal oral route. After entering the oronasal cavity, the virus initially replicates in the lymphoid tissues of the oropharynx, particularly in the tonsils and regional lymph nodes. Within 1 to 3 days post-infection, the virus enters the bloodstream, resulting in a primary viremia. Through the viremia, the canine parvovirus disseminates systematically and targets tissues with high mitotic activity, and the most important target issues include the intestinal crypt epithelium, bone marrow, precursor cells, lymphoid tissues, and in a very young puppies, and the myocardium of the heart. In the small intestine, the virus specifically infects and destroys the rapidly dividing stem cells located in the crypts of Lieberkühn, because these crypts are cells that responsible to replenish the villus epithelium of the intestine. So their destruction leads to collapse of alveoli, villus atrophy, and fusion. As a result, this is severe impairment of the absorption and disruption of intestinal barrier that causes malabsorption, fluid loss, and development of profuse hemorrhagic diarrhea. So the damaged mucosa allows intestinal bacteria to translocate into the bloodstream, predisposing the animal to septicemia and endotoxemia. So simultaneously, the PCV infects the bone marrow, lymph, and lymphoid tissues. Viral replication in the bone marrow precursor cell causes myeloid depletion, resulting to marked leukopenia, particularly neutropenia, or the reduced production of the WBC or neutrophils. This reduction of white blood cells leads to immunosuppression, which further increases susceptibility to secondary bacterial infections. In puppies less than 8 weeks of age, the virus may infect actively dividing cardiomyocytes. This results in myocardial necrosis and lymphocytic myocarditis, which can lead to acute heart failure, arrhythmia, pulmonary edema, or sudden death. However, this cardiac form is now rare due to widespread vaccination and breeding of dams. So, clinically, the combined effects of severe intestinal damage, dehydration, electrolyte imbalance, endotoxemia, and immunosuppression results in
rapid deterioration or acute. Without aggressive supportive therapy, hypovolemic shock, disseminated intravascular coagulation, and death may occur. In summary, the pathogenesis of CPV or the canine parvovirus infection centers on viral replication in the rapidly dividing cells, leading to hemorrhagic enteritis, leukopenia, immunosuppression, and in young puppies, myocarditis. Thank you. As for its gross lesion observed in dog on external examination, the carcass is moderately to severely dehydrated, evidenced by sunken eyes, dry mucous membranes, and reduced skin elasticity. The perineal region may be stained with hemorrhagic fecal material. So, upon opening the abdominal cavity, especially in the small intestine, particularly in the jejunum and ileum, it is markedly affected. So, the intestinal segments obviously, appear reddened and congested, diba? As you can see in the picture. So, the intestinal wall is thickened, edematous, and friable, and the lumen contains watery to hemorrhagic foul-smelling contents. So the mucosal surface show areas of erosion and necrosis. In severe cases, there may be fibrin deposition and sludging of mucosal lining. Serosal surfaces may exhibit petechial to ecmotic hemorrhages. So the mesentery lymph nodes are as seen kanang enlarged, edematous, and congested. And the Peyer's patches may appear, though dili siya makita grossly, but microscopically it appears necrotic or depleted. On the examination of the bone marrow, particularly in long bones, the marrow may appear pale, indicating myeloid depletion. In very young puppies with cardiac form, the myocardium may appear pale and flabby, and the heart chambers may be dilated. So, in summary, the hallmark gross lesion of canine parvovirus infection is severe hemorrhagic enteritis accompanied by dehydration, lymphoid depletion, and bone marrow suppression.
So if your patient has canine parvovirus, this is what you can see histopathologically. So first is your inner crypt epithelium. So you can see necrosis, collapse, and loss of regenerative cells. So this occurs because your CPV targets your intestinal crypt cells because they are actively dividing. So your viral replication destroys these progenitor cells, leaving the mucosa unable to regenerate. So neurodegeneration occurs. So in your villi, we have blunting, fusion, atrophy, epithelial slowing. So with your crypt cells gone, your villi cannot be replenished. So they shorten, they fuse, and eventually slow, leading to malabsorption and diarrhea. So this is why, if you notice, patients with canine parvovirus have diarrhea. So in your lamina propria, edema, hemorrhage, and inflammatory infiltration occurs. So the loss of epithelial integrity allows fluid leakage, hemorrhage, and bacterial invasion. So your inflammation develops as neutrophils and macrophages respond. Then in your Peyer's patches, we see lymphoid depletion and necrosis. So your CPV also attacks your lymphoid tissue, causing immunosuppression. So weak. So this explains the lymphoid depletion and necrosis seen histologically. And in your bone marrow, so leukopenia happens due to progenitor cell destruction. So what occurs is that the CPV damages your hematopoietic precursors, leading to leukopenia. This further weakens your immune defense. And then your secondary invasion occurs. So with this, with villi destroyed and mucosal barriers compromised, your gut bacteria can cross into circulation, causing septicemia. So here I will show you pictures of what you can see histopathologically if your patient has canine parvovirus. So first, in your first picture, we see crypt necrosis. So as mentioned earlier, your CPV replicates in your crypt intestinal cells, so thus leading to necrosis in your crypts. So in your second picture, we see immunohistologic histochemical staining of your parvovirus antigens in your crypt epithelium.